Let me start by reminding you of something that Dr. Anisi said earlier today, and that is that pediatric uveitis is not common in comparison, for example, to adult uveitis, and yet it accounts for a third of the cases of legal blindness as a consequence of uveitis, and that is because of delayed diagnosis and inadequate therapy and chronic corticosteroid therapy. You've just heard from Dr. Whalen that in terms of JIA, which is the most common diagnosable cause of uveitis in children, there are risk factors. One can predict who is more likely than others to crop up with a stubborn case, and that includes younger age of onset, females who carry the anti-nuclear antibody, autoantibody in their blood, and some HLA types or markers like HLA-DR5. So it does make some sense for doctors to study their young patient who comes in with uveitis in an effort to have a sense, at least in the doctor's mind, if not sharing that with the parents, of what are they in for? What kind of a hand have they been dealt? How long are they going to be involved? Patrick emphasized that not only the uveitis, but in fact the joint that you would think would be symptomatic may not in fact be symptomatic. Happily, the joint usually is detected as being abnormal, inflamed, and the child is taken to the doctor, and the doctor recognizes that that can be associated with uveitis, and hence the referral to the eye doctor. I'm going to show you momentarily the crucial importance of that and the importance of, as Dr. Whalen emphasized, the recommendations for frequency of slit lamp examinations. Here are the problems. Here is the accumulated burden, the harvest that the patient and family and the eye doctor reap as a consequence of late treatment or under-treatment of pediatric uveitis, and in particular, JI-associated uveitis. I would call to your attention that these problems develop at a constant rate through time. Notice this bottom line. These data come from the Johns Hopkins Department of Ophthalmology, otherwise known as the Wilmer Institute, and the point is this. One will see publications in rheumatologic literature in the 1990s, for example, that speak to the point of JIA-associated uveitis not being the problem today that it was in the 60s, 70s, and 80s. And those data are really profoundly flawed. The reason that the rheumatologists who wrote those papers had that kind of impression was because the patients had gone away from their practices with great joints, no trouble with arthritis for a long, long time, and seemed to be just fine at the moment when they left the practice. But if one looks at other studies, as many other groups now have done, and asks the question, okay, but what became of those patients 20 to 30 years later, the story is really quite sickening, and that is that they continue to develop problems in the eyes. These data come from the University of Miami, the Bascom Palmer Eye Institute in Miami, Florida, and Rosenberg and her associates looked at a collection of 148 children with uveitis there. I want to call to your attention several features of this. This paper was presented at the annual meeting of the American Academy of Ophthalmology a few years ago. I was asked by the Academy to be the discussant. I'm not sure, but I may have some of my remarks in this presentation. But I would call to your attention that at the moment of first seeing the child, these doctors at this tertiary referral eye care center in Miami found that a third of them already had one or more complication. Notice further that as one followed the patients longer, more and more complications evolved. I'm going to come back to that momentarily, but by 3 years after beginning to see the patient, 86% of the patients had significant eye problems, complications from the uveitis. They concluded that childhood uveitis is significant for developing numerous complications, many of which are vision threatening, and they increase with increasing duration of disease. Back to Hopkins, 75 patients with JI-associated uveitis, percentage of one or more complications, 2/3 of them. At the first moment the doctors at Hopkins saw the patient. Now that's a disgrace, and that's a feature of the care of our children with uveitis that must be changed if there's going to be any change in the outlook going forward into the future from here. Poor vision at presentation secondary to cataract or calcium in the cornea or glaucoma from this yet another group who presented their material in the American Journal of Ophthalmology in 2007. Notice that 36% of them had vision of less than 20/50. 20/50 is approximately the legal driving vision, to give you some sense and perspective. And notice that 1/4 of them were legally blind. Vision was less than 2200. They had had prior surgery. They had adhesions between the pupil and the lens or the cataract. Let me show you a case. Let me tell you first that this case is not unique. This is just a case that I've used as an example of the travesty that's occurring as you sit here this morning all around the world in the care of children with uveitis. POX was 10 years old when I first saw her. She and her mother and a friend of the mother had driven all night to get to Boston, and they were waiting at the door at the moment that the doors opened that morning, and the history was that the child had had 4 years of uveitis in each eye, treated with lots of steroids, drops, shots, periodic pills, and as a consequence of all that, plus the uveitis, the child had developed glaucoma in both eyes that had required surgery in the left eye. The child had had laser treatment, the child had developed cataract, and the uveitis was poorly controlled with many flares and periodic increases of steroid therapy. Steroid drops, cyclosporin drops, dilating drops, and glaucoma drops were being employed, and the child was seeing only the movement of a hand in front of her face in the left eye at that morning of first visit. Her uveitis was active, she had a dense white cataract, and the glaucoma surgery that had been done by a glaucoma specialist looked like this. What you see here is the child's inflamed eye with a white cataract, a hole in her cornea with the tube coming from the glaucoma valve that had been installed some time before, having eroded through the cornea, now with the innards of the eye exposed to the outside world, and so enormous risk of infection and total loss of the eye. The posterior segment seemed unremarkable by ultrasound, and so the mother told us further that she's been begging her child's uveitis specialist to start the child on methotrexate. She had done her own Googling and found that there was something out there more than steroids for treating uveitis. Not only did the person who was caring for this child not have fellowship training in uveitis, not only was this person not taking care of this child correctly, but this person did the additional disservice to this family by ridiculing the idea of doing something more than corticosteroid therapy. Hence the trip to Boston. And so what was done was that the tube was pulled out of the eye, stitched over to the side just to keep it out of my way while I did the rest of the surgery, repaired the corneal defect, took out the cataract, cleaned out all the vitreous gel, and then put the tube back through to try to still exploit that for control of the glaucoma. Now remember, that the glaucoma specialist who had originally done the glaucoma surgery was refusing to do what the child's pediatric ophthalmologist was requesting be done because the eye, after all, was basically ruined and hopeless. This child ends up with a visual acuity of 20/50 in this hopeless eye. Sure, it took a contact lens to do that. Sure, it takes methotrexate in increasing amounts to get her uveitis under control, but the point is that after it's all said and done, this child's uveitis is in remission. Well, this was a few years ago, you see, this was 9 years ago. I'm happy to report to you that this child's uveitis is in remission off all medication. But I can promise you that this kind of story continues. At Mercy, every single week, we see instances of children who have had this sort of care coming finally for evaluation. And there's no excuse for it. There really is no excuse whatsoever for it. The evidence from multiple countries around the world in high-quality, peer-reviewed ophthalmic literature tells a consistent story, a consistent theme, a theme of the importance of adequate therapy and early. Such therapy reduces the risk of complications, it reduces the risk of developing blindness, and such therapy, frankly, is curative. There is a problem, probably through a phenomenon known as epitope spreading, in getting cases late. They are more difficult to get into remission, and they are more difficult to eventually have completely cured, in remission, off all drug. Again, I show you other examples and other slides here simply to emphasize that this phenomenon is a worldwide one. This is not something that we just see in Cambridge or Boston or New England or the United States. Publication after publication throughout the civilized world tells this consistent theme of poor outcomes in patients with delayed therapy and inadequate therapy, and much better outcomes in patients with more aggressive therapy and early on. Here are some of my data from 6 years ago in 89 patients with JIA-associated uveitis. And notice that the outcomes here, 18% of them had visual acuity of 2200 or less. That is to say, 18% of the children had blind eye. And why was that? Well, most of you are parents who have children who are my patients. And so you know my style. You know that we take no prisoners. We will do whatever it takes to get the problem into remission. So how is it that with that kind of philosophy, we still end up with 20% of the patients with a blind eye? It's because of late referral. The same is true for the Hopkins group. 25% visual acuity of 2200 or worse. Why? Because they weren't aggressive enough? They're not good enough doctors? No, not at all. They're outstanding ophthalmologists at Hopkins. It's just that they got their opportunity to treat too late. The same is true at the Bascom Palmer Eye Institute in Miami, Florida. And it's just a consistent theme that goes on and on and on. You'll notice here in 527 children with uveitis, 21% of them with JIA-associated uveitis, over 3 tertiary care centers, Smith's group reports in 2009 these kinds of outcomes, 2200 or less, 9% of presentation. That's unacceptable. What does that tell you? It tells you everything you need to know about current practice patterns, current management of ophthalmologists around the world in caring for the children with uveitis. They're simply hanging on to them too long. Move along. Get that child into the hands of someone who does uveitis for a living. I emphasized to you previously that Janet Davis in Miami and Gary Holland in Los Angeles have tried to increasingly raise our attention to the fact that protein leakage, a measure of vasculopathy in patients with chronic uveitis, does matter. We used to eschew that. Now I'm changing my tune. And I purchased a flare meter for use at Mercy about 2 years ago, and we're using it increasingly in monitoring our patients. So what's a mother to do? You know, it's really, really frustrating. Without adequate therapy, JI-associated uveitis may blind. It may do it slowly, but by golly, it does it surely. The problems like damage to the retina develop at a constant rate over time, and adequate therapy reduces that. Adequate therapy reduces the odds that there will in fact be steady but slow trickle down. What can one do? What can be done to modify these sad prognostic statistics? Well, one is early diagnosis. Early rheumatology pediatrician referral to a uveitis specialist. Early referral, early intervention, aggressive intervention, definitive intervention, rather than the simple expedient of here, take these Pred Forte drops and it's going to be fine. By the by, she's going to outgrow this. It'll burn out. How many of you in this room have heard that? It's disgusting. The number of people that raised your hands just now is absolutely disgusting. And why did you hear that? You heard that because of ophthalmologists who simply have failed to keep current with appropriate recommendations regarding standard of care in the 21st century. Identification of those children who are at highest risk, as Dr. Whalen spoke about, will mean that those patients are followed even more closely than the garden variety patient with uveitis. A limited tolerance to steroids and early aggressive introduction of steroid-sparing chemotherapy or immunomodulatory therapy, methotrexate or otherwise, is the key. It is the number one key to long-term better outcomes and saving the vision of our children. Which of the ophthalmologists in this room, and I know there are a substantial number, raise your hands, present speakers excluded, how many in this room are confident and comfortable with their ability to prescribe and monitor children on methotrexate? None. That also tells you everything you need to know about the model of care that must be employed going forward from here, and that is partnerships. The ophthalmologist in Dracut, Massachusetts, who has the JIA kid, recognizes that this kid needs methotrexate to get him off the steroids. They don't feel comfortable doing it. They link up with a chemotherapist, either a pediatric hematologist or a rheumatologist, and get her done. They can get the job done through partnering with someone who is quite comfortable managing the medications. So people in England and we here at Mercy found that the predictors of poor prognosis included how bad was it at the first time we saw them, how much delay had there been, and how young were they when it first started. Were they ANA positive? Were they male or female? And those kinds of things that can then help drive the decision-making about the therapeutic approach. How aggressive should one be right from the very moment one sees the patient? First, of course, you're going to snuff out all of the inflammation with aggressive use of corticosteroids. Going to survey for possible infection and eliminate that. But you're also going to have a philosophy, an attitude, a bone marrow-based attitude of not simply being hooked on steroids on and on and on, and implement steroid-sparing therapy very, very quickly. You're going to hear more about the stepladder by the by, and so I'm not going to dwell on this. I'll tell you a little story about how disgusted many ophthalmologists in America are with the stepladder.